Uh, the matter is, in this video, the salbutamol, albuterol, also it is named, mainly we know by salbutamol nebulizer, 10 mg in 4 ml of saline to be nebulized over 10 minutes, 4 times the usual bronchodilator dose. Mind that, 4 times the usual bronchodilator dose. Its effect is seen within 90 minutes of nebulization. Serum potassium usually decreases by 0.5 to 1.2 milliequivalent per liter. It works by driving the potassium inside the cell. Sodium bicarbonate. It should be cautiously used in selected cases of hyperkalemia associated with severe metabolic acidosis. So sodium bicarbonate not used all cases, only the cases which are associated with severe metabolic acidosis. Usual dose is 25 milliequivalent, that is 25 milliliter of 8.4%, infused over 5 minutes. Now the step 4 or the step is assess the cause of hyperkalemia. Detailed history and physical examination should be performed to look for features of disease associated with hyperkalemia, such as renal failure and adrenal disease. History of renal disease or potassium levels should be looked for to assess the sudden deterioration of the renal function. Drug history should be taken to exclude the drugs such as angiotensin receptor blocker or ACE inhibitors, non-steroidal anti-inflammatory drugs, aldosterone antagonist, and potassium containing syrup that can cause hyperkalemia, especially in the renally impaired patients. Step 5, that is, you said, for investigations, serum potassium should be monitored frequently, blood urea creatinine, sodium, calcium, magnesium, phosphate, arterial blood gases, complete hemogram, blood glucose, CPK, lactate dehydrogenase. Step 6, stop the intake of potassium. Start potassium-free diet. Step 7, remove the potassium by diuretics. A trial of loop diuretics in patients with preserved renal function and volume overload state may be made. Cation exchange resin, that is sodium polystyrene sulfonate. In the gut, the sodium polystyrene sulfonate takes up the potassium and calcium and magnesium to lesser degrees and release sodium. 1 gram binds to 1 milli equivalent of potassium. It is usually given orally 3 times daily, but may be given rectally. Oral dose is usually 20 gram with 100 ml of a 20% sorbitol solution to prevent the constipation. A major concern with sodium polystyrene sulfonate in sorbitol is the development of intestinal necrosis, usually involving the colon and ileum. The serum potassium falls by at least 0.4 milliequivalent per liter in the first 24 hours. Dialysis is indicated if hyperkalemia persists in spite of above measures or patients have any other indication of dialysis. Hemodialysis can remove 25 to 50 milliequivalent of potassium per hour, with variability based on the initial serum potassium concentration. The type and surface area of the dialyzer used, the blood flow rate, the dialyzer flow rate, the duration of dialysis, and the potassium concentration of the dialyzer. Beware of rebound hyperkalemia after dialysis. Ascertain the cause of the hyperkalemia and manage specifically. Causes of hyperkalemia: increased potassium release from cells. Pseudo-hyperkalemia, that is hemolytic sample, marked leukocytosis, thrombocytosis, vigorous fast clenching during phlebotomy. During phlebotomy, if the patient clenches his hand very vigorously, that can also cause hyperkalemia. Metabolic acidosis, insulin deficiency, hyperglycemia, hyperosmolarity in diabetic ketoacidosis, hyperglycemic, hyperosmolar state, and the octadile infusion. This is given in pancreatitis. Increased tissue catabolism, beta-adrenergic blockade, rhabdomyolysis, digitalis overdose, hyperkalemic periodic paralysis. Succinylcholine can cause huge hyperkalemia. Severe exercise, reduced urinary potassium excretion. In the cases of renal failure, hypoaldosteronism, drugs, diabetes, adrenal insufficiency. Hyperkalemic type 4 renal tubular acidosis. Ureterojejunostomy, when the ureter is implanted into the jejunum. Thank you.